Right, we're keeping the momentum going. We're keeping the momentum going. Next up, we have Jonathan Morris and Bob Morial talking about the Mayo Clinic using immersive technologies. Get seated. They're ready to go. Jonathan and Bob, take it away. Go first.
We're rooted in our values to guide our future. We're achieving significant advancements in patient care, research, and education. We're reinventing healthcare to cure, connect, and transform from within. Our values, our mission, our patience, our calling, our joy, our future.
At Mayo Clinic, we're transforming medicine. You heard that in the line in the video. We're doing that from within. We're transforming through cure, connect, and transform. Those are three new concepts in our Bold Forward 2030 strategy, but it's not so new. I want to take you back. 1883, Rochester, Minnesota. 3 tornadoes came through town, destroyed the town. And that's where Mayo Clinic grew. These 3 gentlemen are the Mayo family, William Worrell, William, and then his other son, Charles. They took care of people in Rochester, Minnesota when that came through town. William Worrell, the only doctor within a 60, 80-mile radius. There were only 3 hospitals in Minnesota at the time. William and Charles were in medical school. And they partnered with the Franciscan nuns in Rochester to be the nurses. And in 5 years' time, they built their first hospital, St. Mary's Hospital, in 1889. We are now in 5 different states, 3 campuses, 3 large campuses in Arizona, Florida, and Minnesota, with a health system in 3 other states in the Midwest. We're expanding internationally with hospitals in Dubai and in England. And this, you may have noticed there are a couple of words on each of these. This is compassion. This is one of our values. Not just compassion for our patients, and we have a primary value of the needs of the patient come first, but we also have over 71,000 employees and over 4,200 learners. In a college of medicine that has 5 different schools. Of course, we have a medical school and a graduate medical education school that has our residencies and our fellowships. Health science school, over 100 different programs across 50 different medical specialties. Our MD, PhD programs are in our biomedical sciences, the school of our graduate school of biomedical and science. And our continuous professional development school. There are over 200 programs that we offer annually. And just coming through the pandemic, we've learned quick, as you all have, to offer the education from afar, digitally, and what we're going to talk about using immersive and experiential learning, immersive tools and experiential learning. This is certainly a school that benefits us, and we're transforming within, but we also teach abroad, and we teach for the greater good through the School of Continuous Professional Development for physicians to continue their certifications.
Sure, thanks, Bob. So my name is Dr. Morris. I'm a neuroradiologist at Mayo Clinic, but I'm a medical director of experiential learning, and we partner together to grow this space. And one thing that's been clear since the very early days of Mayo Brothers operating is they learned on patients. So they learned and became surgical experts by treating patients who had conditions. And even back then, you can see 1927, they said there's no excuse that the surgeon would learn on a patient, that we have to teach other surgeons what we know and benefit from each other's knowledge. And another quote they had is, one day we won't learn from the patient, but yet here we are in 2021. I have 15 residents a year. I'm in neurosurgery, radiology, and anatomy, and we teach people through a graduated progression of responsibilities on patients. So one of the problems with teaching them in cadavers or simulation-based centers or even in the OR is there's one expert, or maybe two experts or three experts. But the expert is teaching people, so you have to be co-located with that expert to get that knowledge transferred from that expert and all of his surgical expertise to other surgeons who may come to Mayo Clinic, who may come to one of our continuing professional development courses, but you have to be co-located. Medical training is very much rooted in the mentor-mentee relationship and teaching people graduated responsibilities throughout their training. And that could be in a simulation center, in a procedural skills center. It could be us teaching people how to do total robotic knee replacements on cadavers, on simulation tools. And here you can see some of this is going to be a little graphic, I suppose, but there's a cadaver arm that someone's operating on that someone's teaching somebody. So we just don't need a virtual representation of that. You know, we need virtual representations as well as augmented physical spaces, because you can't get any haptic feedback as of yet to teach people surgical skills. And there has to be a system, both in the extended reality space but in the physical space, that allow us to do this across the globe. And part of that is why we started an initiative in immersive digital experiences, because we quickly recognized earlier, pre-pandemic, that we needed some of these tools to be able to teach people either A, before they get to the OR, before they get to the classroom, before they get to a place like a radiation cyclotron, because there's only so many of the experts and only so many hours in the day to teach, and we can't possibly teach them everything we now need to know in physical spaces. And I think the pandemic accelerated the progression to where we had to get there. Medical XR gets thrown around a lot in this community, you know, and it's this kind of catch-all phrase, but in essence, it's a big umbrella term. It's the same thing. I work in additive manufacturing, so we've scaled 3D printing in the hospital to 8,000 square feet above the OR. It's a big term, and you have to really say, well, what do you mean when you're talking about extended realities or augmented realities in the operative room? Because it's not clear. Because there's things like this is one of our thoracic surgeons, Shanda Blackman, who's doing a pulmonary artery sarcoma resection, which means they're going to lose a bit of artery, and she's manipulating the images above her, and that's one part of augmented reality, right? It's one part, but that has very specific indications, very specific applications, has to be of no latency disruptions, has to be less than a millimeter accurate, has to be co-registered to a moving target, it has to have machine-learned, co-registered patient-specific data before you get here. There is an entire ecosystem that revolves around this that people don't talk about and or know about, because they just come with a augmented solution, say, I can put that data in augmented reality and put it in your OR. And you say, well, that's great, that's a step, but it may not be helpful. And I can tell you that the expert surgeons, while they like technology, if the technology doesn't work immediately, it goes over there on the counter. And it has to be better than what we're doing today, and it has to lead to better patient outcomes. We just don't add cost to the OR without better patient outcomes or a clinical appropriate reason. And if one of our surgeons, this is Dr. Michelle Clark, one of the neurosurgeons, is going to be in a room, co-present in an operative room across town or across the world or across the country, then it has to work, and it has to work every time. It's not a sometimes, it's not a nicety. Now you're talking about mission critical structure where it has to work. And unfortunately, we're just not there yet. We're getting there. It's exciting. I've been in this space for over a decade, and it seems like we're getting to a place where this can be possible in a way that can be really helpful. There's patient education, therapeutics we're not here to talk about, but one of the things we've done is partner with a company, GibLib. This is Dr. Fred Meyer, one of our neurosurgical colleagues, and he's doing microscopic dissection for a brain tumor, and it's being filmed in passive 360 video. Now, People say, wouldn't it be great if you could interact with them, ask them questions? I can tell you when you're sitting in that chair, you don't want a lot of questions. And if you're the person being operated on, you also don't want the audience asking questions. But it allows people to come in and him just talk out loud, and people that are in our CPD programs to come into an environment and be present in a place they couldn't be present before. ECMO, which you may have heard of during the pandemic, this is a way of taking the blood out of you and putting it in a machine to get oxygen and then putting it back into you. It made the news a lot because they'd say we're out of ECMO devices in state X, or we don't have people trained for ECMO. So pre-pandemic, we were teaching people how to do ECMO in the standard way. We have mannequins, we have groups of people that come, we have a 10,000 square foot sim center, a 7,000 square foot simulation, procedural skills space, and we teach people physically next to us. But when we make videos, we make all this stuff, but we thought, wouldn't it be great if we could replicate this environment so when you physically got to where the experts were, you came with a steepened learning curve. And these are some 3D printed things we make out of our lab. They're 3D printed cannulation models to teach people how to put large catheters in the groin. And it's not like there's not ECMO simulators on the market, but those cost $15,000. And how many of those you're going to buy for how many stations, for how many people, for how many times you're going to teach this? But one of the things we can do is replicate a Mayo Clinic environment. So this is some work we did with a company called Heisenrader, who has an Education XR platform. And in this case, we can bring anybody around the globe into a Mayo Clinic specific room. It's not just an average room. It's not a room and say, hey, we have rooms, we can build you a thing and you can just put any assets in. These are very specific things that we want to teach in a very specific environment that somebody's going to come into to learn how to take the blood out of another person, bring it into a machine, and then oxygenate their blood and then bring it back. And what we don't want it to do is we don't want it to look gimmicky or cheap, because a lot of medical VR stuff looks very cheap because, frankly, medical education does not have a ton of money. So we're having to build design teams to come in to actually teach this. Like, this is a room that I work in. So typically in this room, there could be a cardiac cath lab, a vascular surgery lab, an interventional neuroradiology suite. They're all the same. We have multiple similar rooms, biplane, Philips, or Siemens. But we have to teach people about radiation safety before they get in the room and in the room. At the same time, we're teaching them anatomy. The same time we're teaching them how to use the machine. The same time we're teaching them how to do the procedure, fluoroscopic anatomy. It's an incredibly complex task to do. But again, we partnered with Heisenrader in this case to build out a virtual environment. And it's not a random room. I mean, you have to get the CAD files from Philips. They have to agree to it. They have to allow us to replicate a very specific machine, knowing that we're not going to sell it on the market, that we're using it for medical education. And then we have to teach people how to use the machine, what that machine does, and do it in a way where they can learn the people of the room. So this is not a general room. This is the room that you're going to come into as a patient, as a physician, as a surgeon, as a resident, and we can teach you all different parts about this room. Sorry, kind of jumped forward there. We can teach you all different parts about this room. Whoop, now it's stuck. There's things that we can teach you in this room that we can't teach you in the room. Like, I can't take apart that machine in front of you and show you the different components of this machine, but I sure can in virtual reality. I can put you in the same room, I can talk to you, I can do procedures, but I can show you how an X-ray is created. So we're trying to create single source of information, single source of truth, so our learners don't go to Google, then YouTube, then this website, then that textbook, then this website. That we want our learners to go one place at Mayo Clinic and get their education in a single place where you say, oh, if you're in the cath lab, if you're a neurosurgeon, you can come to this one place. And then when you come in the room and I ask you, which side of the machine does the X-rays come out of, you don't look at me like I have no idea. Another thing we've done is work a lot on photogrammetry capture systems, because another thing is when we take the brain out of someone, either a cadaver or during autopsy, only the people that were present get access to that brain, to that teaching material. And we said we have to create ways to digitally capture. And it's not that photogrammetry is new. It's not that surface scanning is new. It's that we have to create a system where someone with a high school graduate can take an object, put in box, press button, never say the word point cloud, never say the word FBX, OBJ, and all they know is put in box, get out 3D brain. And then that brain, though, then has to be sent to all of our learners. And it has to have educational material with it. And it has to work on any device, in any operating system where any one of the learners are. Because while we will have fixed location extended realities where we have VR and things set up, we're going to have to meet them where they are. And then that system is going to have to go over in some cases, a HIPAA-compliant cloud or a non-regulatory cloud, and then be dispersed around the globe to people who want Mayo Clinic-specific education. Like we just gave an anatomy course this weekend. We had people zooming in from around the world. We have to have ways to get them three-dimensional data and extended realities and building this out. And we did it by partnering with a company Thing, which was an augmented reality company in Chicago, a company BotSpot, which is a photogrammetry company in Germany, and building the entire ecosystem. Because one of the problems for us in medical XR and education is company X comes with a solution. You say, great, that's a solution for a problem, but how does that fit into the global scope of educating 4,200 people with varying education levels? I have to maybe scan a heart and teach someone in an echo school, but also teach someone in cardiothoracic surgery who has a much higher bar of surgical anatomy. So this is an example of that. On the left is a CT scan of a patient who has a specific type of kidney cancer. We go to the operative room, remove that kidney cancer, it goes in box, we get digital file, and that digital file can be 3D printed, it can be put in VR, it can be put in AR, it can be put on any device, 3D on 2D mobile, and it now is accessible to everybody within our learning environment or that comes to our continuing professional development schools in a way that it was only present to the people in frozen section before and then discarded as medical waste. So we're building an entire library of both autopsy, anatomic dissections, and surgically removed specimens to have digital three-dimensional pathology that is accessible to any one of our learners anywhere they are on any device they are. And even that in and of itself is still a lofty goal. We partner with we have a Department of Medical Illustration and Animation that Bob used to lead. And we use those kind of animations and 2D animations to partner with our 3D printing skills. So that's a cadaver that was CT scanned. Then we 3D printed his skull, put anatomic data on it, but then that data has to exist where that 3D printed model doesn't. So it goes into the cloud, into the ecosystem, and it comes down on any user's device. So the end user has the information where they are, not where we are. That we're putting the experts in the system so that we can get more expertise to more people wherever they are. This is another example in the Department of Anatomy. So on the left is Dr. Wojcik, who's teaching a student. You can see there's organs in formalin, in containers that we store thousands of. You say, oh, we're teaching heart. Let's pull out all the heart abnormalities from the archives. And you teach, and you can't touch it. It's in formalin. Eventually, it's going to degrade. Eventually, it's going to be destroyed. In the middle, you see 3D printed objects. So these are 3D printed objects that are either cadaver-based or they were part of patients' care. We have an entire industry at Mayo that's just doing 3D printing for patient care. And we take that data and we put it in the educational ecosystem to create enduring educational material. Like here's Nirusha Lagman, the chair of anatomy, teaching a cadaver head that's 3D printed, right? But that same digital data has to run as a thread in an AR space. If we're looking down at cadavers, we don't necessarily need cadaver replacements. We need to augment the cadaver experience. There's benefit. It's great to have cadaver replacements when you don't have cadavers. Or during COVID, we used high-definition cameras in pro section because students couldn't gather around cadavers. Or some parts of the world can't use cadavers because of religious exemption. But still, in our country and throughout Europe, cadavers are a great a tool. On the right, you see that's all the vasculature that's inside of your abdomen. Even if you add a cadaver, you cannot dissect that out. So that's education material made from CT scanning that becomes a 3D digital file that then has to be distributed. And here it's being distributed on one of the Zoom classes that we had for our anatomy. And I'm going to turn it back over to Bob because doing all this requires a new way of thinking about the governance of all this.
Because it can't just happen as one-offs, and they're happening today. And it's not to say that we don't make progress that way, we do. And those were great examples. We've got more. But in a way in which we're working to redefine and transform medicine, we're doing it from within. And we've got priorities, we've got strategy that we think will help move this forward, particularly within our college and all across the schools. But this is just a sampling of three primary priorities that we have at Mayo, which is visioning and strategic planning to create this foundational element within our college. And then we have the organization is funding this, using capital dollars and operational dollars to build what we're terming right now as an XR-enabled hub. You'll see it here Well, on the next slide, I'll show you that it's going to be a foundation across all we do for immersive and experiential learning. This gives you a sense of, just visually how we want it to connect to the 5 schools, live within the college, and we've got, high priority strategies to lead change. And one of those priorities is strategic partnerships. We know we can't do this alone. And so that's why we're here today, sharing what we're doing and hoping to make connections. Real quick, just we're not going to focus on necessarily the organizational structure here, but the one thing I'd point out on this org structure is that, do you see the blue and the red there? That's one's an administrator, the other's a physician. This administrator-physician partnership is key to Mayo, and it's the way in which we maintain a way forward that allows us to, pay attention to the business strategy and also understand what's important to teaching future physicians, future care providers. And then we'll end on this. And this is just really a map to say, who are we partnering within? We've got a bunch of different strategy happening with building out a healthcare platform from within. We've got our cloud and IT developing. We've got, as I shared earlier, we've got 2 international hospitals. How do we connect them? How do we maintain high-level quality education? Dr. Morris?
Yeah, I think it's the last slide. So I think, as you can see, there's elements that exist in the practice that immediately come into, and when we say practice, we're talking about practice of medicine, in the OR, in the wards, in the clinic. There's things, if we build augmented reality, stereoscopic navigation for, say, guiding a saw through a bone, which is something that we're working on right now, that immediately then gets transferred, that technology gets transferred over to the medical school, over to the orthopedic surgical resident, and we're augmenting cadavers, we're augmenting virtual things, we're augmenting the physical parts of the procedure and creating VR environments to teach people how to do it. So it's kind of a big picture. We have an entire new part of the Cure, Connect, Transform, Bold 30 vision is digital health. So Mayo Clinic is making a really large investment in transforming from pipeline to a platform. How do we get to platforms of delivery of health where we can touch as many patients as we can, both digitally as well as those that are going to come to us? Because many of you realize Minnesota is in the middle of the country. It's the #1 hospital brand in the world, and yet we're in the middle of Minnesota. So there's a lot of good places to fly over before you get your care at Mayo Clinic. So we have to provide the best possible care across all our disciplines, which means we have to have the best possible education system, because 70% of our staff come from our own internal education programs. And we'll just end with that, and we're not going to take any questions, but we'll be around throughout the conference. So we're really thankful that we were invited to come here. Those are our LinkedIns if you want to take a picture of it, and thanks a lot.
Thank you.
Yeah.
All righty, everyone. Yes, I know the question in your minds. Yes, it is that time for a break. We will break. We will be back for the next session at 11:20. Thank you.